and then you splint it, and then you put it either in plaster, fiberglass, long arm, short arm, pronation, supination, neutral. You know, I can't even keep straight where these things are supposed to be now. I don't know how anyone expects it. The important thing is you try and get the wrist in the most anatomic position you can for a couple reasons. One, it's more comfortable, right? The body's designed that way for a reason, so let's try and put it back where it belongs. Two, it helps with swelling, whether it's going to be treated operatively or non-operatively. Anatomic alignment helps with the swelling. And three, median nerve or other issues can have if they're widely displaced and left alone. As far as the immobilization, I've seen great plaster casts, I've seen great fiberglass, and I've seen horrible plaster and horrible fiberglass. I think it's important to just use what you have and what you trust and what you know and what you feel like you're most comfortable with. Long arm or short arm. I know we put at UHS most into a long arm or a sugar tongue. There's some good literature out there saying short arm casts can do well, short arm plaster can do well. Once again, which article you read, depending on the day or the time, can change what you feel like you should be doing. I think the important thing is just doing what you're comfortable with. And then pronation, neutral, and supination. If you're doing a short arm, that doesn't matter, right? If you're doing a long arm, then I generally say put it in neutral unless there's some sort of instability of the ulna, and then a little bit of supination is better. But the reality is if that kind of thing is unstable, it's something that probably needs surgery, so putting it in a comfortable position is probably more important. You'll see, I think we're getting a little bit more aggressive on what to operate on as far as distal radius fractures are concerned. But the big thing is encourage them to move their fingers, especially the older population, because what happens is, you know, y'all are the front line, right? A lot of times they get reduced, looks great, says, okay, you need to go see a hand surgeon, and then they call my clinic, and my clinic doesn't do a very good job of getting them in within a day or two. Sometimes it's a week, and then they come in, they haven't moved their fingers or their elbow, and then I fix the wrist, and the biggest problem is not the wrist, it's the fingers. So I always tell patients, regardless operative or non-operative, move the fingers aggressively, and patients love to do this thing, a little wave, maybe the Queen's wave at most, but you really want them getting a lot of flexion at the MCPs because that's what gets stiff in the long run. That's the hardest thing for me to take care of, and if you reduce it and it displaces with them moving their fingers, well then you know it's going to need surgery anyway, so I'd still rather have nice loose fingers.